The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Hello, everyone. Welcome to the next episode of TMD Demystified. It's Tuesday morning, and we're here to educate, enlighten, encourage the proper treatment of temporomandibular joint disorder. I am Tony Urbanek. Today's episode is entitled Changing Paradigm and TMD. Changing Paradigm and TMD. There is an old paradigm for treating this problem that everyone continues to call TMJ. Now, that's not a major issue with me, but it does represent how backward, that's the proper word, how backward the profession is, and everything emanating from the profession of dentistry regarding this problem. You would think after 50 some years that through the educational efforts of the dental profession, that the word would get out to call this anything but TMJ, which is just the name of the joint. Everyone has knees, and you don't go to the orthopedic surgeon and announcing if you have a problem, you don't go in and announce that you have knees. But if you have a problem with this joint, the dentist and everyone associated downline just call it TMJ. I have TMJ. I have actually two TMJs. But that's just an indicator of the current paradigm regarding this disease, which is properly called temporomandibular joint disorder. And you might want to call it something else, but TMJ is definitely not appropriate. But the paradigm that we are currently operating under needs to be changed to a different paradigm, because the information, the proven information, is out there exactly how this disease operates. And the old paradigm does not know that. The old paradigm is operating from the position that this joint is different. This joint is so unique is the reason that no one could figure out the disease. But we'll talk more about that in a minute, be specific. But we definitely need a new paradigm, because if you operate from the old paradigm of admitting you don't know how the disease works, you'll never be able to come up with a solution if you start out admitting you don't even know what the pathophysiology is the correct word, the mechanism of what's going on with this disease called temporomandibular joint disorder. I've spoken on it many times, and I'm sure many of you may be tired of hearing it, but it is one disease. All of these symptoms are generated, all of the disparate symptoms are generated via chronic inflammation within the temporomandibular joint. If you can make the chronic inflammation go away, you make the symptoms go away, you make the disease go away. It's that simple. And fortunately, it wasn't a big step to figure out how to make the inflammation go away by unloading the joint with a device that takes the load off the joint by separating the posterior of the back teeth, according to a protocol. You can't do it just any old way you want. The patients and the doctors who supervise or oversee the use of this tool need to know when and how to use it, and under what circumstances, and what variables might occur while one is using it to bring the patient through the maze. It's not a big maze, but the judgment calls that are necessary to get the patient from start to finish. Very simple. So a new paradigm is needed, but let me tell you that how I have arrived at this conclusion. A new paradigm is needed. And see if anyone would like to disagree with me. As I've always said, I'm open for discussion. I'm open for statements. I'm open for criticism. I'm open for new information if anyone would like to share it with me. But my job as an educator, and although I did spend 55 years in private practice, I actually was designed, my training was designed to bring me into the academic world. And right at the end, I decided the academic world was not going to suit me, and I decided to come out into private practice, but I'm fully trained as an academician. So let me tell this story again. I've said it before, but I think it's time to bring it to your attention again regarding this paradigm, the current paradigm, and the need to change the paradigm. So back in 1972, I was a junior in dental school at Indiana University School of Dentistry and was invited, along with a half a dozen of my other classmates, to attend a clinic which at that time was called dental medicine. That's what the clinic was called, dental medicine. I had no idea what was meant by the term dental medicine. I assumed at the time that it probably had something to do with the interface or the coordination between dentistry and medicine. And I was somewhat correct, but when we showed up in the clinic that day, it was manned by one of the professors in dental medicine, and basically what it was that clinic that day had 3 patients that they wanted to show us young students that had TMJ, better known as temporomandibular joint disorder. I really didn't understand the whole process until it was all over with, but over the next hour and a half, once the clinic started, the professor brought in a series of 3 females who in sequence, first of all, gave their history, and all of those historical events, all those symptoms that they gave off were symptoms of temporomandibular joint disorder, a variation of headache, earache, jaw pain, neck pain, ringing in the ears, subjective hearing loss, fullness in the ears, dizziness, vertigo, upper back and shoulder pain and tightness, arm, hand, finger tingling and numbness, and various kinds of jaw locking. And as the professor went through each of these patients one at a time and collected their symptoms and then did an examination, which primarily was an intraoral examination, looking at the bite and seeing if there was anything unique about the intraoral examination, and then put a stethoscope to the joint itself, listening to joint noises, which he made a point that was very important, which it's not. And then at the end of each examination, taking a history, he did look at x-rays, had an x-ray of the temporomandibular joint, and then told each patient that they had TMJ, and then prescribed anti-inflammatories, non-steroidal anti-inflammatories, and that was the end of it. And he went through 3 sequential patients, similar. They weren't identical. The symptoms weren't identical, but they all had symptoms in that list of symptoms that I just gave you. At the end of, and the students and myself were just standing around watching, listening, And at the end, last patient walked out, and a couple of my fellow students had a question or two, and I hesitated to ask what else he prescribed, and I failed to tell you he also prescribed a night guard. He prescribed anti-inflammatories, non-steroidal anti-inflammatories, and then a night guard. A night guard covers the teeth and protects the teeth so you can't damage teeth and bruxism. So my fellow students asked a question or two, but at the end I hesitated, but I finally had the courage to say, sir, I can understand how anti-inflammatories will work to decrease inflammation, but how does a night guard treat this problem? And he hesitated a little bit, eyeballed me, and then he gave me an explanation that didn't make any sense at all. I couldn't follow him at all. To me, it sounded like word salad. He didn't apply any of the basic sciences to it. He just kept saying that if we put this night guard in your mouth, it will help the temporomandibular joint problem. And that was 1972. Since then, it's been 50 years since I've been addressing the problem of temporomandibular joint disease. The first 36 of my career surgically, doing 2,000 temporomandibular joint surgical cases, half of them open joints. I did every kind of temporomandibular joint surgery multiple times, several of them, several kinds of surgery, hundreds of times. Half of them open joint and half of them through an arthroscopic surgery, watching your surgery on TV as you manipulate your instruments inside the joint. But 15 years ago, I decided that surgery was not going to be the long-term solution to this problem, and did the research and actually figured out how chronic inflammation creates each and every symptom. I didn't make the basic science that proves this. The basic science is there. All I did was read the basic science, apply the science, connect the dots, and then show how chronic inflammation within the temporomandibular joint creates headache, earache, jaw pain, neck pain, tinnitus, ringing in the ears, subjective hearing loss, vertigo, dizziness, upper back and shoulder pain, arm, hand, finger tingling and numbness, and various kinds of jaw locking. If you take away the chronic inflammation, the symptoms go away or they never show up. That's the fact. But yet, 50 years later, here in 2026 are undisputed facts about how the current paradigm treats temporomandibular joint disease. And I'll read these off, and then I'll read them and talk a little bit about them as we go through it. First of all, 50% of dentists prescribe a night guard to treat TMD, but can't explain how it's supposed to work. Just like the professor in 1972 who couldn't explain to me how a night guard was actually going to make the symptoms of temporomandibular joint disorder go away, 50% of the dentists in 2026 still make a night guard, but can't explain how it works, but give it to the patient, expecting the patient to use it and for the symptoms to diminish and go away. Of course, every week we see patients who come in with sometimes a paper bag full of night guards. I had one yesterday who had multiple night guards, and we're told by several different dentists that this particular night guard was going to work. And of course, her comment was, sometimes these night guards make it worse. The other 49.9% of the dentists, 49.9%, don't want anything to do with temporomandibular joint disorder because they leave school, they leave dental school, where they are taught next to nothing about the temporomandibular joint or temporomandibular joint disease, except that it's complicated. It's complicated because it's a complicated joint. They're taught it's a unique joint. It's a joint unlike any other joint in the body. Again, they'd never be able to figure it out unless they start out from the point of view that, no, this joint operates like every other joint in the body, under the same mechanisms, the same biochemical, neurological, anatomical circumstances and science that any other joint in the body operates on. But yet, 49.9% of dentists, when they hear the word TMJ, they put their fingers in their ears, they close their mind, tell the patient they don't do that, they don't want to do it, it's complicated, and send them away elsewhere. Frequently to the oral and maxillofacial surgeons, who's supposed to be the smartest guy in the room, who basically operates under the original paradigm, that it's complicated, nobody knows what to do. And nowadays, after a couple decades of temporomandibular joint surgery, early in the 1980s and into the early 1990s, many oral surgeons were operating temporomandibular joints like myself, but nowadays you can hardly find a oral and maxillofacial surgeon who wants to do anything, wanted to have anything to do with temporomandibular joint surgery. There are still a few who do temporomandibular joint surgery, but they are not very common. Let's just leave it at that. And then there's that 0.1% that I call TMJ gurus, who the kindest thing I can say about them is they focus on treating symptoms rather than the cause. And they treat the symptoms in many different ways. And at very best, it's very localized and very temporary, if there's any effect at all. And of course, the most common one, as most of you probably know, is Botox, botulinum toxin A, which paralyzes muscles. If you have a painful area in your face or your neck or your shoulders, go ahead and paralyze the muscle, and it won't hurt anymore because the muscle's not stimulating the nociceptors where it's attached to the bone, so it won't hurt anymore in that one particular muscle. But what about the other areas of the face or the other non-painful symptoms that are involved with this disease that are totally ignored? Totally ignored. And then you have to come back every 3 or 4 months, and if it's hurting again, then you get another injection, and it goes on forever. And I have multiple patients who have spent thousands and thousands of dollars, and the one that beat everyone was the lady who came in. She says, I can show you my receipts for $200,000 of Botox over 10 years. And came in with the identical symptoms she started out with 10 years prior, with $200,000 of Botox, $10,000 of Botox per year. That is amazing. So the other issue on the other side of this is the medical doctors who try to treat some of these symptoms. The first one in line is migraine headaches, and medical doctors, of which I am one, and I know my colleagues well, how they operate, how they think, what they do. Basically, if they think you have a migraine, then they throw drugs at it periodically, trying to find the drug that works the best. All of the drugs, all they do is suppress your entire nervous system, and you have to accept all the side effects that come with these drugs, when actually the whole problem is not suppressing the nervous system. The problem is making the inflammation in the temporomandibular joint go away by unloading the joint. But the medical doctors use drugs, and the science on their side admits they do not know what causes migraine headaches. They have lots of theories. We've been through that before. They know it has something to do with the trigeminal nerve. And it does, because that's where the signals of the autonomic nervous system travel up and down the trigeminal nerve to cause the muscles of mastication, and then the neck muscles, and then the shoulder muscles, getting signals to tighten up, to hold this whole joint still. Hold it tight, hold it still, let the joint heal. That's what the brainstem is saying. So I thought I'd share a diagram briefly. I've showed it before, but today it applies also. I'd like to share this diagram. You don't have to read the whole thing, and I'm not going to bore you with it, but it basically is a diagram that I ask the assistance of artificial intelligence to produce for me, which basically shows how the autonomic nervous system in the area of the reticular formation. What's the reticular formation? It's the combination of all of the nuclei of the cranial nerves in the brain stem up to the pons that are very tightly closely packed together. When they get the signal from the temporomandibular joint that the joint is inflamed and the joint is damaged and the joint is not healing, it's in the reticular formation that these signals arrive, and then it is in the reticular formation that goes between and among the different nuclei of the cranial nerves, giving signals to don't move the joint. And depending on what happens in the reticular formation, these signals to tighten the muscles, to hold first the jaw still, then the whole head still, and the neck still, and then the upper shoulder girdle quite still. It's giving these signals just tighten up, don't move the jaw joint, and that is the originator of the painful symptoms that move around between the head, the face, the headache, the jaw pain, the neck pain, the upper back and shoulder pain. And it is in the reticular formation that actually is not even addressed by the doctors who treat symptoms because they don't understand the disease. Very, very simple. So you have the medical doctors who are treating migraine headaches and can't define what actually a migraine headache is, what causes a migraine. Then you have your ENT physicians, otolaryngologists, who try to treat the Meniere's disease, ringing, fullness, dizziness, tinnitus, ringing, subjective hearing loss, that fullness in your ear, dizziness. If you go into an otolaryngologist or referred in by your primary care physician or a convenient care clinic to an ENT doctor with one or more of these symptoms, you'll have a big workup done, very expensive workup, more than likely having an MRI, and then be told that you have Meniere's disease. And when you look at the doctor and say, oh, thank God we know what it is, how do we treat Meniere's disease? And the ENT doctor will shake his head and say, we have no solution for Meniere's disease. But it works out. It is common knowledge in dentistry that patients with temporomandibular joint disorder commonly also have ringing in the ears, subjective hearing loss, and dizziness. And when you make the inflammation in the joint diminish and go away, those three symptoms diminish and go away. Different mechanism. That mechanism has to do with inflammation going through the petrotympanic fissure into the middle ear, getting the same inflammatory process, inflammation, but inflammation getting into the middle ear where your hearing mechanism and your vestibular mechanism reside, which is only literally a quarter inch or so from the temporomandibular joint through the petrotympanic fissure. And then finally, the number of people that are misdiagnosed with ear infections when it's really temporomandibular joint disorder. If you have ear pain, if you have earaches, if you have constant severe earaches, you will get an antibiotic because the person who examines you may or may not see any change within the external auditory canal, but I can promise you, you will leave with a prescription for antibiotic when actually the cause is inflammation within the temporomandibular joint, which stimulates the external auditory canal to make it feel like you have earache, ear pain. The the distance, the space between the temporomandibular joint and the extra auditory canal, it sometimes is paper thin or actually can have a hole in the bone itself, allowing inflammatory influence, inflammatory fluids to stimulate the inside of the external auditory canal and feel like an earache. So that is a description of the old paradigm. That is what's been going on for 50 years, better than 50 years. And all the information that explains actually how temporomandibular joint disorder works, the pathophysiology, the mechanism of how it works, has been in the literature for the entire 50-year period of time. Why I was the one who was picked out to actually figure it out, I question myself sometimes. To me, it was obvious. It was absolutely obvious when you put the concepts together, connected the dots, understood the basic sciences, anatomy, cell biology, possibly because I'm trained additionally as a cell biologist and anatomist. I have a separate degree in cell biology and gross anatomy, well versed with the anatomy of the head and neck, and also spent 2 years under the tutelage and fellowship of the National Institute of Health, National Institute of Dental Craniofacial Research, doing a 2-year fellowship project on facial growth and development. So there needs to be a new paradigm, and the paradigm is simple. If you haven't followed me along, let me just spell it out clearly. The paradigm is the disease itself needs to be reclassified as simple chronic inflammation within the temporomandibular joint, and that chronic inflammation creates the disease symptoms, and that treating the symptoms is not the appropriate way to go. Treating symptoms is a waste of time and money and effort. Treating chronic inflammation, and of course chronic inflammation can be treated with non-steroidal anti-inflammatories really well, but they're very short-term in their ability to decrease the inflammation. As everyone knows, dentists knows, physicians knows, and patient know, that after a few weeks at best, 1 or 2 or 3 weeks, no matter how much anti-inflammatory, non-steroidal anti-inflammatory you take, ibuprofen or aspirin, all you're doing is going to tear up your stomach, make your stomach hurt, and it doesn't have any more effect on the inflammation. It basically runs out of steam. If non-steroidal anti-inflammatories work well, that's all we'd have to do, and I'd encourage that. I'd vote for that, but they are very short-term. But we know they work, which proves the point. If you can make the inflammation go away, the symptoms go away, and the symptoms go away during the first 2 or 3 weeks when you use non-steroidal anti-inflammatories, but beyond that, they're not effective, at which point the most effective thing you can do is unload the temporomandibular joint long enough, according to a protocol, which allows the inflammation to decrease. When the inflammation decreases, the symptoms go away. That is the new paradigm. But getting that across to my fellow professionals in dentistry and medicine is very difficult. Getting it across, meaning they listen, but they don't, and they understand, but they don't accept. And the reason that it is not accepted readily is something called condition or conditional bias. They're biased in the old paradigm because the old paradigm suits them for one reason or another. The old paradigm doesn't work. The old paradigm is what they're used to, and they have a lot counting on the old paradigm in their communication and treatment of patients. They have a lot riding on that, and so they're biased on the old paradigm and changing someone's bias. And there's a whole lot written on the psychology of conditional biopsy, bias, conditional bias. A whole lot written psychologically about this, but that is the problem. But it's not a new problem. It is not a new problem. There has been many people who have come across trying to change a paradigm and find it very, very difficult. Basically, 500 years ago, they put Galileo, who proposed that the Earth is not the center of the universe and that the sun does not rotate around the Earth, just the opposite. And he was put on house arrest for the rest of his life because of the bias that he experienced 500 years ago. So this is not new. I'm not whining about it, but I am bringing it to the attention of anyone who wants to listen, especially my colleagues. My colleagues in dentistry, my colleagues in medicine, especially my colleagues in academics, especially my colleagues in dental schools, who continue to teach that this joint is unique, complicated, unlike any other joint in the body, which is just not the truth. It is not factual. All right, with that, I've spent 30 minutes of your time listening. I hope it's been educational. I hope it's meaningful. I hope you can use it, because information is not valuable at all, has no valuable if you cannot use it. So I encourage listeners, especially my physician and dental colleagues, but also patients who can take this information to their dentist or come to our website. If you have this problem, TMD, you can find a professional, a provider like myself here in Middle Tennessee, who use this device, because they have to get licensed to do it. They have to learn how to use it correctly. But there are doctors now in 20 states who use the device that we finally conceded and had to call the Urbanek Device and Protocol. All right, with that as the summation, I look forward to next Tuesday morning when I'll spend 30 minutes on a associated, maybe similar, maybe dissimilar topic, but all having to do with making TMD demystified. I am Tony Urbanek.